Sorry. So dry eye is a really hot topic. There's a growing prevalence, and almost 20 to 30% of our OPD patients, if you see them, do have a dry eye problem or they complain of dry eye symptoms. Most of these patients are pretty unhappy, and it affects the quality of their life. You often go doctor hopping. They are underdiagnosed, and they're often dismissed as khujli pani patients. It's frustrating for the doctor too, because it's a multifactorial causation, and they are chronic patients who are difficult to satisfy. Now we know the pathophysiology of dry eye. The Dew's classification has shown us that evaporative dry eye is the major cause, and meibomian gland dysfunction is a very important part of this, along with the environmental factors, hormonal changes, dysfunction of the meibomian glands, along with changes in the meibum. There's inflammation, there's obstruction of the glands, and all this leads to a chronic issue with duct obstruction, inflammation, and keratinization. So how do we diagnose dry eye? Of course, we need to do a detailed examination. The first thing is to do a dry eye questionnaire, do a slit lamp examination, look at the morphology of the glands, do a gland expression, do the tear breakup time, Schirmer's and corneal staining. But now we have a very useful tool, which is the ocular surface analyzer, and this at one point, it can give you a very detailed evaluation of the ocular surface. So we've been using this now for almost 2 years, and it gives a very nice and easy to do dry eye workup. You get the non-invasive tear breakup time. You get the meibography, where you can see the dropout of the meibomian glands. You can see the tear meniscus height, along with the lipid layer evaluation. And more important than anything, it gives a printout which is easy to explain to the patient. Because when you're seeing dry eye, you're seeing the meibomian gland problems, it's difficult to explain to the patient that this is a chronic problem. But when you show them the printout and you actually show, where the issue is, they are much more amenable to treatment and follow-up. So now there are many management modalities for MGD. Of course, a lifestyle and environmental modification, reduction in the digital screen time, sensitizing the patient about their blink rate. All of that needs to be done, along with warm compress and massage, giving the tear substitutes, anti-inflammatory medications, immune modulators, and all. So we have so many things, but at the end of the day, many of the patients still do not get relief, and many of these traditional therapies are inadequate. So what do? We feel often we feel helpless how to help these patients. So now the intense pulse light therapy is our new kid on the block, and it has been used in dermatology, in fact, since '94. And it was Toyos et al. Who first reported it, incidentally, the benefit in dry eye in 2002. And since then, there have been a large number of publications, and its use in MGD has been well documented now. The mode of action is it's a polychromatic light with a wavelength of 500 to 1200 nanometers. It works on the principle of photothermolysis. The light is directed to the skin. It gets absorbed by the chromophores, such as the melanin, hemoglobin, and all. It develops heat, and this causes the blood vessel ablation. Baumler et al., they demonstrated that even a single pulse of IPL, it helps to coagulate the large blood vessels. And it is these blood vessels actually which are releasing the inflammatory modulators, which are triggering the MGD. And this is how, the basic concept of IPL is based on this. It also causes the fluidification of the meibum. It causes photomodulation, demodex eradication. It has an anti-inflammatory effect. So it's a multi-mode action, actually. Along with this, you have the low-level light therapy, which utilizes a longer wavelength, which is the red light. And this causes a photobiomodulation, where it stimulates the meibomian glands both in the upper and lower eyelids. It increases the meibum production, and thus, consequently, it improves the tear breakup time. So we have the iLight. It has a dual advantage because it has both the IPL, the intense pulse light therapy, as well as the low-level light therapy. So we give most of our patients, we give them these synergistically, both the technologies are used. And the procedure itself is very simple. Our optometrists are trained to do it. the intensity depends on the patient's skin type. So first we check for the skin color. It's an automated mode in the machine. And based on the score, the amount of light given is modulated. An eye shield is placed to protect the iris. And 5 flashes of light are given along the lower lid till the temple. And this is then followed by the mask therapy. After that, we do a manual expression on the slit lamp, and you can actually see the mebum flowing out. So our experience has been, over the last 20 months, we've done about 150 patients, of mostly mild to moderate. 50% of the patients improved with just a single sitting, and about 30% required 2 sittings, and very few needed more than 3 sittings. Some of the chronic patients have required a repeat procedure after 6 months. Normally, we give a gap of 3 to 4 weeks between 2 sittings, and most of the patients, they show within 2 to 3 weeks, they start showing improvement in the symptoms and reduction in the medications which are required. And on a long-term basis, it's found that the tear breakup time and the ocular surface staining also shows improvement. Side effects are almost negligible. You have to protect the iris. We use protective glasses because the iris can absorb the light, leading to a little mild iritis. And very transient effects on the skin, like some tingling sensation or erythema, and very rarely you get some pigmentation or blistering. Soothing gels can be advised, and you should advise the patient to avoid exposure to sunlight. Of course, in very darkly pigmented patients, we have to be cautious. So my take-home message is that dry eye is almost a pandemic now with increased digital screen usage. And in fact, we've seen a lot of children, school kids, who have been coming to us with meibomian gland dysfunction. And a timely diagnosis and treatment is important, because once it goes into the chronic stage, the treatment becomes very difficult. The conventional therapies are only giving supplements from outside, but we need to treat the actual cause of dry eye, which is from the meibomian glands itself. And the newer modalities like IPL and vector thermal pulse are useful, but I have preferred IPL because I feel it addresses the main issue of inflammation and the meibomian glands, whereas vector pulse is just a expression of the mebum. So this has been very safe, effective, and repeatable. And of course, a longer follow-up would be required to see the duration of efficacy. Thank you.
Thank you, Dr. Aurora. That was a lovely talk. I just wanted to ask you, you've said that in certain patients you have had to repeat the sittings. So how long do you normally wait before you do the next sitting?
See, normally we would, at the outset, we tell them that you need 2 to 3 sittings. Now, most of them we found that even with a single sitting, they become so comfortable that it's difficult to tell them to, go for the second.
Yes.
And I have had one patient in whom, she asked me after 6 months that, doctor, I would like to repeat it.
Okay.
She was actually very happy, and she said, and now I'm getting a slight irritation and all.
Okay.
And she asked for it. And actually, there have been only 4 patients in whom we've had to repeat it after 6 months. I would wait at least for 6 to 8 months before giving a 4th sitting.
Thank you